Hello and welcome to all of our attendants and participants in our ORL Tanta meeting and monthly meeting. You are all welcome. We are the Otology group and the Tanta ORL department, the great department in ENT in the center of the Delta. We bring you today a hot topic, a very important topic for all otologists and for all ENT surgeons. It's the facial nerve surgical anatomy. Facial nerve. We will talk about all aspects of the facial nerve, and we will begin with the facial nerve surgical anatomy. First of all, it is the seventh cranial nerve. As you all know, the anatomy is long and complicated anatomy, but knowledge of this is imperative to all otologists because it's very, very important during any otological surgery to identify all aspects of facial nerve anatomy. We have three main parts. To make it simple, the intracranial, cranial, and extracranial parts. We'll begin with the intracranial part and the origins and the high centers. We have the primary somatomotor cortex and the precentral gyrus. The neural projections continue through the pyramidal tracts. Most of the fibers cross the midbrain to reach the contralateral nucleus through the pyramidal decussation, and a small number of fibers innervate the ipsilateral nucleus part for the temporal branch of the facial nerve. This is why the central lesions usually spare the forehead muscle, because the upper half of the facial motor nucleus usually bilaterally represented from the pyramidal tracts. The nuclei, we have the facial motor nucleus, which is formed by the neuroblast and the pons. As the pons expands, the sixth nucleus ascends to the facial nerve fibers. So the facial nerve fibers, especially the motor fibers, curve around the facial, the obtusant nucleus and the pons. So any inflammatory or vascular events or pathology at this area will involve both the facial and the abducent. We have the congenital Mobius syndrome, usually with agenesis of the facial and the abducent nuclei. And we have the nervus intermedius. So the two main trunks, the nervus intermedius and the facial motor branch. The nervus intermedius is responsible for taste, continuous sensation, lacrimation, and salivation. It exits the brain stem adjacent to the motor branch, usually clunges to the eighth cranial nerve before it joins the motor branch, and it has three main parts and constituents: the general visceral, special visceral, and general sensory. Here we have a picture of the nervus intermedius and the motor branch as they enter together the porus of the internal auditory canal or the internal auditory meatus. So the first part of the nervus intermedius is the general visceral. It carries the preganglionic parasympathetic neurons that innervate the lacrimal, submandibular, sublingual, and minor salivary glands. The cell bodies of the neurons are present in the superior salivatory nucleus, present at the upper part of the medulla. They travel together until reaching the geniculate ganglion that gives off the greater superficial petrosal nerve that innervates the lacrimal gland. The second part of the nervus intermedius is the special visceral part. It supports the chorda tympani nerve, which receives input from the taste pods of the anterior two-thirds of the tongue, as well as the heart and soft palates. Their cell bodies are present in the geniculate ganglion and will eventually synapse in the nucleus solitarius and the medulla oblongata. So the nervus intermedius has special visceral and special sensory and general sensory. General sensory is for a limited area in the external auditory canal, usually the concha of the auricle. It enters the spinal trigeminal tracts, of course, without synapsing into the geniculate ganglion. And we have here the Hesselberger sign. It's very old, but it is positive in case of vestibular schwannomas in advanced cases when it compresses the facial nerve. So it causes tingling or numbness or loss of sensation at the concha of the auricle. Now, after exiting the brainstem, they pass into the cerebellopontine angle, both the nervus intermedius and the facial motor to join together to form the main facial nerve trunk. The CB angle is the space bounded by the cerebellum bones and temporal bone, contains short intercranial courses, not only of the seventh, also of the fifth and eighth cranial nerves. So we have here the posterior cranial fossa and here the cerebellopontine angles on both sides. So the cerebellopontine angle has the cranial nerve number 7, facial, highlighted in yellow, and the vestibulocochlear, highlighted here in yellow. Both pass together through the cerebellopontine angle. The CV angle in the facial nerve during its lateral course through the CV angle changes position with the vestibulocochlear nerve, so by rotating 90 degrees. And in the CV angle, the facial nerve covered with pia, pads, and CSF devoid of veneurium, and this is a very risky site and makes the facial nerve highly susceptible to trauma, not only by the vestibular schwannoma or meningioma or any CV angle tumors by itself, but also during removal of the tumors through middle cranial fossa approaches. Usually the facial nerve is at high risk of trauma, even when using also the facial nerve monitor. Here is a nice endoscopic view of the CV angle. Here we have the cranial nerve number 5, number 1, and the facial nerve is number 3. Look at number 3, you will find the facial nerve as it enters the IAC. Number 5 here is the ICA, anterior inferior cerebellar artery. And number 9, look at number 9, it is the labyrinthine artery. Number 9 is the internal auditory artery or the labyrinthine artery. This is the endoscopic view of the CV angle. Now, after the intracranial part, it will enter into the cranium, into the bone, to pass into a canal called the fallopian canal. This is the cranial part. The facial nerve enters the temporal bone along the posterior face of the petrous bone, passes through 4 regions. The 4 regions are the IC, internal auditory canal, then the labyrinthine segment, then the tympanic segment, then the vertical mastoid segment. This part length is approximately 3 centimeters, and it passes within the facial canal called the fallopian canal. It's a bony canal. Here is a quick reminder of the temporal bone. Here is the skull from lateral view, and here is the temporal bone with its 4 parts: squamous, petrous, mastoid, and tympanic. Here is the squamous part and the zygomatic process, the temporalis muscle insertion, and here is the petrous part from inside. We have the arcuate eminence and the cavum trigeminal. Okay, let's go back to the facial nerve. First, it will pass through the IC, internal auditory canal. And the internal auditory canal, the length is 1.2 to 1.5 centimeter from burus to fundus. Here is the IC in cadaveric dissection. The lateral portion of the IC is divided into by transverse segment called the falciform crest into upper and lower portions. The superior compartment is further subdivided by vertical crest called Bell's bar into 2 compartments. So here is the IC from inside. Here is the Bell's bar, vertical crest, and here is the falciform or transverse crest. So we have 4 quadrants of the IC. The facial nerve occupies the superior and anterior quadrant. Here is the nervus intermedius, highlighted in yellow, and the facial motor nerve. Both enter in the superior and anterior portion of the IAC, highlighted in yellow. The superior vestibular nerve is superior and posterior. Here is the opening in the IAC. The cochlear nerve is anterior and inferior. Here is the opening in the IAC. And finally, we have the inferior vestibular nerve, which is inferior and posterior. And here is a special opening highlighted in yellow for the singular nerve from the posterior circular canal, which is highly important in benign proximal positional vertigos when we do singular nerve neurectomy in resistant cases. Then we go to the labyrinthine segment. It is the narrowest portion of the fallopian canal. This segment is the narrowest portion of the fallopian canal, less than 0.7 millimeter. This is why they suspect that edema and inflammation cause paralysis in this area, especially Bell's palsy. The geniculate ganglion is the end of this part, located immediately superior to the cochlea, beneath the middle fossa plate. And it gives, of course, the greater superficial petrosal nerve, as we said before, anteriorly to be joined by the deep petrosal nerve to form the Vidian nerve through the Vidian canal to reach the lacrimal gland and the nasal mucosa. Here we have the facial nerve, the intralabyrinthine part, then the tympanic part, FNT, the tympanic part, and the geniculate ganglion by red arrow. Here we have another view. Here is complete dissection, the supratuberous recess exposed, a removal of the attic to expose the facial nerve, geniculate ganglion. Then after the labyrinthine segment, we have the tympanic segment. After the geniculate ganglion, or by the end of the geniculate ganglion, facial nerve makes its first genio. This part is 1 centimeter long. It's positioned just superior anterior to the cochleariform process. The cochleariform process is one of the processes present in the medial wall of the middle ear. It's one of the excellent anatomical landmarks, especially endoscopic ear surgery or during mastoid surgery. Then, or during canal wall down surgery, then travels posteriorly along the medial wall of the middle ear, passing superior to the oval window and the stabes. All this tympanic segment passes along the medial wall of the middle ear, of course, above the oval window and the stabes. Then the nerve reaches the posterior wall, and the mastoid curves sharply inferior to form a second genio, just posterior to the oval window, the pyramidal process, and the stapedial tendon, and anterior to the horizontal semicircular canal. This portion is highly susceptible to trauma. This is the surgical importance of this portion. Usually trauma with facial nerve occurs at this portion, the second genio. Abnormalities of this portion include dehiscent canal. So the facial canal is dehiscent, especially during stable surgery for stapedectomy. You will find the facial nerve prolapsing all over the oval window. Most of the surgeons terminate the surgery and never continue because of fear of injury of the facial nerve. Maybe branching facial nerve if to branching, or it even may pass below the stapes. These abnormalities should be put in mind during surgery because it may cause injury to the facial nerve and facial palsy. This is an endoscopic view of the middle ear. This red arrow represents here the facial nerve that passes above the stapes here and the oval window. Here is the incus and the Emilius, and this is the facial nerve as opposed to the root fallopian canal. And here is the cochleariform process, as we say. This is the insertion of the tensor tympani tendon. Here is another endoscopic view of the middle ear. You will find here very clearly the facial nerve. There is the chorda, the Emilius, incus is removed, and the stapes to visualize the facial nerve. So the facial nerve passes above the stapes. That is the stapes head, and here's the stapes tendon, and here is the facial nerve as it passes through the medial wall of the middle ear. Then we have endoscopic view, another endoscopic view. Here is the stapes removed to show the oval window, and here is the facial nerve. Here is the lateral semicircular canal, the antrum, and here is the promontory. You see the relation between the facial nerve and the stapes and the oval window. Here is one of the anomalies. For the time, I got only one picture for the anomalies. Here we see the facial nerve below the stapes. Look at the stapes here. This is superior, this is inferior, anterior, posterior, and here is the stapes. Look at the facial nerve. It's below the stapes. Sometimes it's branching, sometimes it's prolapsing all over the stapes. We have to take care of these anomalies. This is the facial nerve passing below the stapes. Then we go to the vertical segment. After the second genio, the nerve passes vertically through the posterior wall of the middle ear en route to the stylomastoid foramen. It gradually here assumes a lateral position. This vertical segment is highly important, especially in surgeons doing mastodectomy, cochlear implantation, canal wall down. Very important during mastodectomy. It gradually assumes here lateral position, making it more susceptible to trauma. Here it gives two branches, gives the nerve to stapedius muscle, inferiorly gives the chorda tympani nerve, superior nerve to stapedius, inferiorly gives the chorda tympani nerve. The vertical segment, here the angle between the chorda tympani and the descending portion approximately 30, and delineates a triangular space, very important, called the facial recess, which is now the axis for the round window and the stapedial tendon, especially in cochlear implantation surgeries. Performing posterior tympanotomy goes through this facial recess, and it's formed by the relation between the chorda tympani at its origin and the facial nerve and the annulus, tympanic annulus. In its most inferior portion, the facial nerve takes a close proximity to the digastric ridge and muscle, where the nerve consistently medial and anterior to the digastric ridge. So, the most important landmarks of facial nerve while performing cortical mastoidectomy. Let's see this picture. First, we have anterior to the medial to the lateral semicircular canal. This is the lateral semicircular canal. It's anterior and medial to it. The short process of incus will be here pointing towards the anterior border of the facial nerve, and here is the digastric ridge. The facial nerve will pass medial and anterior to it. This mark is very important, so we'll take many pictures to explain them. This is a right ear mastoidectomy, posterior tympanotomy. Notice here, this is the posterior canal wall. This is the tympanic membrane. Here is the incus, the lateral semicircular canal, and this is the posterior tympanotomy, and here is the facial nerve. Look at the facial nerve. Usually the facial nerve doesn't pass like this. It passes with a curve like this, and here gives the chorda tympani, so it forms the facial recess, showing the round window here. So short process of incus, lateral semicircular canal, very important to identify during cortical mastoidectomy, to identify the facial nerve. As our professors told me always, facial nerve is your friend, not your enemy. Look for it to avoid its injury. So this is close view of the posterior tympanotomy. We have here two anatomical structures that usually confuse some pathologists. Here is the buttress and the chordal crest. After you open the posterior tympanotomy, you will find this crest called the chordal crest represent and the buttress. The buttress represents the short process of the incus from inside, and this is the chordal crest, and here is of course the facial nerve, the relation of the buttress and chordal crest to the facial nerve. Let's see these steps of posterior tympanotomy illustrated. This is a mastoidectomy, complete mastoidectomy, the lateral canal, the incus, then the incus short process, lateral canal, the facial nerve. Then you will drill here to expose the posterior tympanotomy. You will find this is the chorda tympani, this is the buttress, and here you will find the round window when you extend the posterior tympanotomy approach. Let's see another picture. This is the 3D facial recess. Here, of course, the posterior canal wall is removed to show the facial recess in 3D. You will find here the facial nerve. Here is the origin of the chorda tympani nerve as it passes through the middle ear. And here is the tympanic membrane. And here you will find the facial recess. Another picture of here showing the facial, the tympanic, and the mastoid segment. Of course, here the posterior wall was removed, the semicircular canal is drilled out. Here you will find the cochleariform process. This is a right ear, by the way. And this is the tympanic part of the facial nerve. This is the second genio. This is the tympanic part. This is the second genio of the facial nerve. And here is the mastoid part of the vertical part of the facial nerve. Here is the round window, the promontory. Here's the oval window, stapes was removed. You can see here also the lateral canal, the posterior canal were drilled out to show the relation between them and the facial nerve. Here also we can see the facial nerve exposed here and the short process of incus, in relation to the jugular bulb. As you see below the facial nerve, this is the sigmoid sinus, this is the posterior canal wall. You see this relation. This is very important. You have to memorize this. Look always for the landmarks, look for the facial nerve to avoid its injury. You will identify it from the landmarks you have to know and memorize. This is extended canal wall down procedure. Here to see this is the Marius incus. Here is the promontory, the round window. You see the facial nerve completely skeletonized and exposed, the mastoid part. Here is the sigmoid sinus. Here is the internal carotid artery. Here the relation between facial and internal carotid artery, which is anterior, and the anterior wall of the middle ear. Finally, we go to the extracranial part, which exits the skull base through the stylomastoid foramen between the mastoid tip laterally and the styloid process medially. At the styloid foramen, it passes, of course, after to the parotid gland within its substance, typically as a single large trunk. Usually it may branch before, but usually as a single large trunk. This is, of course, important for neck surgeons, and it divides within the gland into temporofacial and cervicofacial branches, which gives what we call the bis anserinus, the duck leg, the bis anserinus. Here is an example of that. This is the facial nerve within the parotid, gives what's called the bis anserinus right here. This is an important landmark during parotidectomy and exits from the anterior border of the parotid gland as 5 terminal branches, which are the temporal, zygomatic, buccal, mandibular, and cervical, all supply muscles of facial expression. like 5 digits of the hand. Thank you, and I hope this was informative. Thank you all for attending. Thank you very much.
Thank you, Dr. Haytham, for this very nice presentation, really illustrative. I like very much your illustrations, very useful. Now we go to the, will you stop share, please, Dr. Haytham? Now we go to the second lecture, Professor Mahmoud Mandoor. He will be talking about the radiology of the facial nerve.
Assalamu alaikum.
Mahmoud.
Hi, good morning or good evening, everybody.